started.
Well, hello everyone. Hello everyone. I am Ignacio Pérez Arriaga, the Interim Director of the African School of Regulation. Welcome to this ASR webinar on electricity access and healthcare in Sub-Saharan Africa with our guest, Luke Severi, who is the Program Manager for Powering Healthcare at Sustainable Energy for All. The webinar will be moderated by my colleague and external expert advisor to the ASR, Louise Mathu. Luke Severi has a long career in international development management, starting in 2009 after finishing 2 masters in commercial engineering and development management at 2 prestigious universities. He has worked for 5 years in the field in the electrification of rural communities in Mozambique and Senegal, and also in Liberia, managing health and education projects. Now at Sustainable Energy for All, he continues working on electrification of vulnerable rural communities and specifically on off-grid and semi-isolated rural populations. He has recently participated in the publication of the Sustainable Energy for All report, State of the Market for Healthcare Facility Electrification. The topic of today's webinar is obviously of great importance as it brings together electricity access on the one side and health facilities. From the viewpoint of the ASR, we are particularly interested in how a sound regulation can help in achieving business models that will deliver sustainable and reliable supply of electricity to health facilities. We want to learn from your experience, Luke, and to disseminate that knowledge in our capacity building activities. So welcome to the ASR and congratulations for the critically important work that you are doing. And Louise, the floor is yours.
Thank you so much, Prof. Ignacio. Good morning, good afternoon, good evening, wherever you might be. Thank you so much for taking time to join us on this ASR talk. Very, very interesting topic and very, very pertinent to us. As Prof has introduced, my name is Louise Mathu. I'm regulatory expert supporting the ASR as an external consultant, and I'm delighted to be here. So without further ado, well, let's start this conversation with a poll. You might have read the introduction talking about 100,000 health facilities without reliable access. But let's start with a poll, an interesting poll, and you should be seeing it on your screen now. What is the number of health facilities in Sub-Saharan Africa that have no access to electricity? What is the number of health facilities in Sub-Saharan Africa that have no access to electricity? We have choice A, 35,000, choice B, 10,000, C, 25,000, and D, 18,000. We can just get started and see, what do you think? What is the actual number? We'll give you a couple of seconds just to complete that before we start this engagement. What's the number of health facilities in Sub-Saharan Africa that have no access to electricity? What are your thoughts on that? I think the poll is about to close. What do you think the number is? I think we can close the poll now, so then we can get to the substance and see. Okay. I'm not really able to see how many people have voted, but there's no harm. The number is actually 25,000 health facilities with no access. So the figure of 100,000 covers those that have unreliable access, but those that have no access whatsoever is 25,000. And you can see that this is quite an important issue and which is why we've taken some time out at the ASR to hold this important conversation. So without further ado, Luke, Severi, welcome. We are so delighted to have you on the back of the Sustainable Energy for All releasing this very, very important and insightful report. And for those who've not had a look at it, we'll invite you, take time to look at it, even after we conclude this talk. I'm sure you'll find some wonderful insights there. Luke, welcome. I know it's very early where you are. Welcome. Thank you so much.
No, happy to be here. Thank you.
That's fantastic. Thank you so much. So look, let's dive into this report. All right. The report itself states that it's really unique. It's taken a bottom-up approach, leveraging the most up-to-date data from 387 initiatives from 78 stakeholders in 89 countries. Quite some statistics there. But just tell us a little more about this. What does that mean that this report has taken a bottom-up approach in arriving at the contents that we have in the report? And why is it such a good resource for those who are interested in this topic of electrification of healthcare facilities? Luke?
Thank you. So let me just backtrack about a year ago when we published together with WHO, IRENA, and the World Bank, kind of the first of these big flagship reports called Energizing Healthcare, which took more of a top-down approach. So it basically tried to look at all the data that is out there in terms of electrification access data in the health sector. That, of course, is very much dependent on that data, first of all, existing in a handful of countries or in the majority of countries. And then, of course, that data not being super outdated, not having too many gaps. So that report tried to essentially compile and collate all the data that we had that we could find and that we could then kind of validate as well to come out with essentially the number that you put out there, which is about 25,000 facilities, health facilities in Sub-Saharan Africa have no power. That corresponds to about 15% of health facilities. And then on top of that, like almost another 70,000 health facilities in Sub-Saharan Africa lack access to reliable power. Now, these are assumptions based on the data that we know. Now, this year, we published a new report called The State of the Market, and we wanted to get a sense of not just how big is the gap, but actually saying, what is the progress towards it? What are we seeing? What has happened in the last 5 years? What do we see happening today? And what do we see coming up in the pipeline? Both in terms of the volume, of course, of the number of interventions, but also trying to see if we can distill some of these trends, right? Like what sets some of these projects apart? And that is really what we set out to do. And that, to me, like, it really makes this project a unique one, because it is grounded in close to 400 different projects worldwide, some of them electrifying one small clinics, other electrifying 500 clinics. So they all differ in terms of size and scope and scale and geography, as well as the technology that they're using, for us to allow us essentially to come up with certain trends, as well as use those trends to then look forward to say, where do we see potentially the sector heading towards in the next 5 years? Because, of course, you know, we have 25,000 plus 70, like almost 100,000 health facilities in Sub-Saharan Africa alone that clearly require a new, robust power solution. They need it yesterday. But of course, like if we want to put ourselves a deadline, a milestone, I think 2030 and the end of the Sustainable Development Goals is an appropriate one. So we essentially wanted to see how far off track are we? If we first knew a year ago how big the gap is, now we know how much off track we are, and how much essentially our progress needs to not only continue but accelerate.
Thanks a lot for that, Luke. That must have been quite a task, I would imagine, to gather all that data using that approach. And we are grateful to Sustainable Energy for All for putting in that work. I'd like to encourage the audience, if you have any questions, please feel free to post them in the Q&A box, preferably, so that we're able to consolidate them as we continue. And we'll endeavor to answer as many as we possibly can. So please feel free, engage with us. So thanks a lot for that, Luke, as I said. You mentioned something quite interesting, just picking up off of what you said. The key trends that have been captured in this report. And indeed, the 2023 report by World Health Organization, the World Bank, SEforAll, IRENA had highlighted quite a few things. And this report indicates some trends talking about the adoption of data-driven decision-making, adoption of GIS increasingly. I think we're particularly interested, as Prof. Ignacio also mentioned in his introduction, on business models. Maybe you can tell us a little bit about that. What are the business models that have been adopted for healthcare electrification, and then now moving where we are and also projected into the future? What are they likely to evolve into?
Yeah, so thanks for that question, and kind of starting immediately with the Holy Grail, with the hardest one to answer, and it's good because we have a lot of time left on the clock to try and get us as far as we possibly can. Let me just take one quick step back and say, like, the trends that we're seeing include like a trend, for example, on technology, where I think most people on the call today will understand that the technology that we're using today, especially the composition of what makes up, say, a solar home system, a solar mini grid, is very similar to what it was 5 years ago and what it's 10 years ago. Yes, we're using lithium-ion batteries instead of lead acid, et cetera, et cetera. Solar panels are getting more efficient, but ultimately it's the same way of constructing a power generation solution, which is solar panels, batteries, cables, inverters, and then of course appliances. So that hasn't changed, and we don't necessarily see that changing. We see some small tweaks on the technology side, on the hardware side, in terms of remote monitoring coming in, and of course, as I mentioned, components becoming much more efficient and much more affordable, right? So that we do see as a trend, like that the system sizes are increasing, which makes sense, of course, for the same for the same dollar or pound or euro that you have, or national currency, you're able to buy much more than you were 5 years ago or 10 years ago. So that's a positive trend. Another trend that is maybe not really highlighted in our report, but that I just want to highlight as kind of this trilogy of where technology is the first pillar, the second pillar is logistics. We know how to do this, and like as a sector, as an energy access sector, we know how to deploy renewable energy solutions very far into the most remote areas. And I wanted to put these two pillars first because I do want to highlight that this problem of how do we electrify clinics 10 years ago, we would have talked more about technology still, like we're only able to power the vaccine fridge. We don't have enough power for everything else. There's no energy efficient appliances, etc. Or we would talk about the logistics pillar. Like it's too hard. It's very difficult. It's very costly. We don't know where these clinics are. They're hard to get to. Pillar 1 and pillar 2 on technology and logistics, I feel like we've tackled them as a sector, both in the health sector as well as in the energy sector. Pillar 3 is on finance. So that really is like that remains the biggest barrier. That is going to determine whether or not we're able to electrify every clinic by the end of this decade or not. And finance, like you can cut it in multiple parts. You can think about, like we just need more funding and financing, and we need both, right? We need the right type of financing, the right type of funding at the right moment to really make a dent, because it's one thing to put a solar panel on a rooftop. It's a very different thing to make sure that that thing is working a year from now, 5 years from now, 10 years from now. And that is kind of one of the other trends that we're seeing, unfortunately, but it's quite normal, is that many of these power solutions that are being deployed, they typically don't reach their natural end of life. Like a battery has a natural end of life with today's technology, 8, 9, 10 years perhaps, and that would be fine if we can reach that. But typically we see these power solutions kind of breaking down because like a $3 fuse breaks, and we don't know where to get the fuse, and nobody at the clinic knows how to get the fuse, plus the $3 is not available, right? Like it's both human resources and financial resources over time that are not available. So that leads me to your question on business models. And we talk about public health here, public primary health, especially because that is, public primaries, rural areas. That's where the biggest part of the energy access gap sits in the health sector. So I prefer to talk about delivery models, because when we talk about business models, typically people think about profit making, private sector driven approaches that we just need to somehow remove a barrier, and then the private sector will solve all our problems. And that is just simply not the case. What is true is that there's definitely a much more expanded role for service providers, which are typically private sector actors, that we need to unlock. But given that we're talking about public health, and especially public primary health in the majority of cases, it's the risks are just too high for us to assume that it's going to take the same route as household electrification, because the majority of these smaller clinics are staffed by a nurse, a midwife, and a security guard. There's no accountant on staff there. There's no budget. There's no bank account even. There's no budget autonomy in many cases either. So your client is not your customer, right? And that makes it very complicated. And that means that in many cases, a private sector actor or a service provider will not automatically say, hey, here's a school, here's a clinic, here's a public institution. I'm going to electrify them, and these people, this institution is going to pay for its bill. It's going to pay for its energy bill, because because of all the barriers I mentioned, right? In terms of ability to pay, the affordability gap, willingness to pay, they're not where they need to be for service providers to be able and willing to take the step, to take the risk and say, we're going to take a 7-year, 8-year, 9-year gamble in a way and electrify them and assume that we will recover our costs. So what is also true is that in the household sector, electrifying households, we have seen increasingly an energy as a service model kind of making massive inroads, and in different variations, right? In different variations, whether that's leasing, whether that's pay as you go, whether that's a flat fee on the mini grid, whether that's actually paying for consumption. They're all variations, but ultimately it comes down to somehow the payment is not linked to the asset, as in it's not the solar panel that you pay for, it's the kilowatt hours that you pay for. It's the kilowatt hours that you use. So that's kind of the idea that we're trying to look at in the health sector, in terms of how much can we replicate, how much can we take from that energy as a service model, and then what needs to be added in, or what needs to be de-risked further to allow an energy as a service model to kind of proliferate in the health sector in a handful of countries in Sub-Saharan Africa. And I'll just give one big example, of course, is around affordability and ability to pay, which is if you're the service provider and you approach a clinic and they have no budget autonomy, they're not going to be allowed or able to make that decision. So you're going to have to talk to perhaps, say, like a district health office, or in some cases at the central level with the Ministry of Health. And essentially, your service contract is with the Ministry of Health. And if you are a service provider and you want to sign a 10-year agreement with the Ministry of Health, you will think about 10 years being 2 presidential election cycles and maybe 3 ministers of health that you go through. So how can you assure that those contracts will be honored? Vice versa, the same is absolutely true as well. Show me which energy access company has been around for more than 10 years while they're trying to get 10-year agreements. So the risks on the public sector side are also quite big, of course, because this is quite new. We're still not very clear in terms of how to cost things out, how to appropriately budget for operating and maintenance, with a few exceptions. I think there are a few sectors that have done it extremely well, but Anna, let me pause there. I don't know if you have a follow-up question on business models, because we could talk about this all day, and sometimes we do. But back to you, Louise, for a sec.
Okay, thanks so much for that, Luke. It's really insightful. I mean, when you also draw attention to the fact that we're talking about public health largely, which is quite different. Investing in that space also has so many challenges, so many of which you've mentioned, also related to the political climate in the country, change in regime. Really, it's quite something. Also, I like also what you pointed our attention to, looking at the technology angle, logistics, and the finance. The finance is, as Prof also likes to say, the elephant in the room. Which just brings us to the next question, which was actually on the funding and financing. So the state of the market report indicates that the investment gap, the funding gap, is $2.5 billion. Sorry, I think I may have dropped off.
Yeah, I think we lost you. You mentioned the $2.5 billion, and then I lost you, and then I got scared that I was the one who was being cut off. But no worries, go ahead. You're back.
Yeah, so sorry about that. Sorry about that. Yeah, so you talked about the finance, which is still a challenge. So what can be done about this, Luke? What are your thoughts about that? How can this funding gap be addressed? $2.5 billion. A lot of the funding is now in the form of grants, donor fund. It's just not sustainable in the long run. What are your thoughts around that? How can this gap be addressed? And
So
also sustainability. You
Yeah.
can also touch on the sustainability component so we can have a holistic answer.
Yeah. So to me, both the number of close 100,000 health facilities in Sub-Saharan Africa need a new robust solution, a power solution, and the $5 billion globally, or the $2.5 billion for Sub-Saharan Africa. Those numbers are both big and small. Like, they're big in the sense, like, I cannot comprehend what that means. Like, I've never held it in my hands. I cannot imagine like 100,000 clinics in a row. Like, it's too much to comprehend. But it's small in the sense that as an energy sector, as an energy access sector in particular, I mean, how long does it take us to electrify 100,000 households? Every month or so? No, like maybe even less than that. Like, we electrify millions of people every year. So that's what I mean in terms of, like, logistically, this can be done. Like, this is not really that complicated logistically. But it comes down to, how do we bridge the financial gap that we know exists? How do we accelerate, for lack of a better word, investment in this space? And that's like what becomes clear in what I tried to highlight in my previous answer around energy as a service and sustainable business models, is that there's a role for both, right? There's a role for public funding / grant funding / concessional finance, and then there's a role for kind of like return-seeking finance as well. But both need to be in play, and that first group really needs to be in play to de-risk. This gap exists in, as all of you will know, probably in certain countries where the national currency fluctuates heavily and tends to devaluate against the dollar. So if you're a service provider, in many cases, all your obligations are in hard currency, dollars, euros, pounds, and all your returns are from the clinics, the people, like the households that pay to you in national currency. So if your national currency over 3-4 years devalues by 50%, you don't have a business model anymore. Like, it just, no business model can absorb that shock. So that's why there's definitely still a need for public funding and for grant capital to come in, whether it's to reduce the initial cost of connection, like in the form of some kind of a subsidy, whether it is to reduce a tariff, more like an end user subsidy, whether it is to be parked somewhere as a first loss fund in the event that a bill is not paid, somewhere as a guarantee, or all of the above, right? I think that is where, I hesitate to, no, this is sometimes my concern that I've seen in the last 2 years, and this is not a trend that we see in the State of the Market report. This is more me speaking. What I hope we don't end up with is all of us as a sector pushing for this one rural clinic in Malawi needing to be more financially sustainable than a clinic in Europe. Because the health sector in Europe is not financially sustainable in and of itself. right? Like it also depends on public funding, which comes from taxes, which comes from health insurance, and there's many other ways that a health sector is funded, and the majority of those ways currently don't exist yet in the countries where we're focusing on today. So that to me is where do we want to be 40, 50 years from now? Of course, is working in countries where the tax base has increased and like people have stable jobs, they're able to pay taxes, that those taxes go into a public budget. Part of that goes to subsidize the health sector. The other part, of course, is health insurance, which is another way to kind of generate revenue and spread it out more equitably to ensure that everyone has access to health services. But what I want to avoid is us thinking like all the money that needs to come into the sector needs to come from the private sector, and we need to find ways to get them a return on investment. That's a very dangerous way of thinking because of all the risks that are included in working with a public sector, and working with a public sector that provides a human right. Public health, public primary health is a human right. So I think it's about finding the right balance between what type of funding and financing needs to come in at what stage, and to which actors, to ensure that we're able to get more sustainable outcomes. Like no one will argue that what we have today is not good enough. But yeah, I think we want to be realistic as well, where I feel like I've said this almost every single day this year already. I guess it's my new thing for the year. The perfect is the enemy of the good. And we can wait another 10, 15 years and wait for a few countries to have the right conditions to come up with the perfect business model where we de-risk and we guarantee, and the private sector comes in because, and capital is cheap, and we electrify 1,000 clinics. That is 15 years that those clinics don't have power, and that to me is unacceptable, right? So we need to be okay with sometimes taking incremental steps and saying this new project is not perfect yet, but it's better than the previous one, right? Like we're pushing the barriers always further and further in terms of how many years of O&M is included, in making sure that O&M becomes cheaper by including remote monitoring, by trying to look at remote monitoring and O&M management at the national level, empowering ministries of health as well to play a bigger role. The last part that I wanted to talk about in my answer is, so far, you mentioned grant capital coming, like grant funding coming in, public health funding, public funding coming in. The majority of funding has come in from the energy access sector, energy access donors, energy access kind of like soft investors that have come in, that have tackled this project, this problem. On the back of the pandemic, the health sector has really, really stepped up. We increasingly are seeing, WHO has always been there, but like WHO, UNICEF, Gavi, and a lot of health NGOs taking this issue much more seriously. And for better or for worse, for worse or for worse, like the pandemic has played a role in elevating this topic and ensuring that many more organizations, also from the health side, are taking this issue seriously and are understanding that we have an amazing opportunity to close this gap once and for all. The third group of stakeholders that is still largely absent, which we can't ignore anymore, given how big that sector has become, is the climate space. Climate funding, climate financing. And that is where, increasingly, we as an organization are investing in the data that is required to bring the climate finance actors to the table. So data around not saying how many clinics have no power, but saying how many diesel generators are running at every point in time over in an average day. How many liters of diesel are being burned? How many emissions does that equate to? How many clinics have no power and their best source of power would be kind of like a baseline, a counterfactual? What would their only realistic opportunity if they needed power tomorrow would be a generator, right? So we can talk about emissions avoided, we can talk about emissions reduced, and that is the type of language that also applies much more to larger facilities that are already connected potentially to a very unreliable grid. Think about a lot of the capital cities in the countries where we're working on. Grids are still quite unreliable. So lots of these hospitals have huge diesel generator plants on site that they run 6 hours a day. right? That is a lot of diesel that can be avoided, where you're not only talking about access, you're talking increasingly about reliability as well, and you're talking about the source of generation being renewable. So that kind of language is what we have started investing in last year, but as a sector, we definitely need to invest in much more to ensure that some type of climate funding, climate financing starts to flow to the sector. And the last thing I'll say again is like $2.5 billion. Like, please check out the health budget of, say, like the PEPFAR program, which is probably like 3 times bigger than what we need as an entire sector annually for them. Look at how many billions of dollars go into the climate sector every year. 2.5 billion is not that much. It's not that much. But we need to find it, right? And today the biggest projects that we see out there, unfortunately, they're still in an order of magnitude of like a couple of tens of millions of dollars or euros or other currency. So we need, we need many more of those, but we also do need like 1 or 2 of these flagship, huge, grand challenges that go out and say, we'll tackle half of the problem and we'll do it in 3-4 years, which is absolutely doable. It's just, we need to find the right coalition to do that. Over.
Thanks so much for that, Luke. It's true what you say. The amount is large yet small, and I think I do recall watching a recording of one session at last year's COP, where there was a discussion on healthcare electrification, and the same point was raised. This money can be found. It really can be found if there's the right people. And like you've said, this is not only for public it's not just public. It's not just a private sector thing. It has to have the input of both public and private sectors. I also like what you said about getting started. It may not be perfect, but we must get started. We must start somewhere and find solutions along the way. We maybe rework things, but we must get started. Otherwise, like you say, in 15 years, nothing will have changed, and we really must get started. I also like that you highlighted about the opportunity in climate finance. I believe this is also pointed out in the report as one of the opportunities that can be harnessed to raise financing. I think I saw a mention of the use of renewable energy certificates in that context. So quite something. I think also something that I've taken away from what you've spoken about is really now the those in energy access now getting more involved in healthcare electrification. Indeed, one of the trends that's captured in this report is that there is more collaboration between energy sectors and healthcare sectors. Previously, I think this was highlighted in the previous report, World Bank, IRENA, Sustainable Energy, that it seemed these departments or ministries were working in silos, but now since the pandemic, there's been more collaboration. So a lot to take home from what you've said, Luke. We look forward to seeing what more comes of this in the next few years.
I'll be back here in 5 years to say about how we close the gap, how every clinic has reliable.
Indeed, we hope that we will have really improvement, real progress having been made. And we at the ASR are very excited to have this conversation. As we said from the title, it's an initial conversation. There's so much to be said. We really cannot exhaust it all. So I'd like to encourage the audience again, if you do have any questions for Luke, you can hear he's got quite a lot of experience in this space. Please feel free to post them in the Q&A and we will pose them. So if we can just then talk about regulation. Luke, the African School of Regulation, as Prof said, our aim is to ensure that we have sound energy regulation in Africa, for Africa. So many problems that we need to solve in the energy space. What would you say? I think you also alluded to this previously. What would you say really are some of the key regulatory interventions that can help bridge this healthcare electrification gap that we're talking about? I think you may have alluded to that, maybe tariffs and the like, but please tell us, share your thoughts with us, Luke.
So I think that there are several angles to this, and I guess the good news is that in a couple of months we will be publishing something close to like a policymaker's guide to powering healthcare, right? Like what would you need to know? What are some of the, basically, no, to flip the question, like what are the foundational pillars on the policy side that we would like to see in a particular country that we feel and based on experience that we see could accelerate health facility electrification and could accelerate it also in a more sustainable way? As again, like the perspective being policy at the national level. I start with, as with most of my answers, with data. So, when we think about regulatory framework policy, we think about big bills. We think about, like, I like to start about data and actually think about what can a government do, what can a Ministry of Health / Energy do on the data side, and kind of ingrain that and manage that properly to allow projects to to pop up faster and to also to be more efficient. And that's especially data. Like, you may think it's very simple to think about data on health facilities in terms of their location, but even that is sometimes difficult. Like, it's sometimes difficult to walk into a Ministry of Health or a Ministry of Energy and say, please show me a list of all your clinics with GIS data, whether they're connected to the grid, yes or no. Very difficult, because that data is hard to collect because these clinics are super remote, and there's a census every 10 years, right? So it's this data tends to be outdated very quickly. But that data, and then if you supplement it with more columns around what kind of power solution do they have? Do they have a generator? Yes or no? Like, quality of power. Like, are they connected to the grid? Yes, but how many power cuts do they tend to have on average per week? How many other power solutions have been deployed? Who deployed them? When did they deploy them? What O&M regime is that under? That kind of like big dynamic database at the national level allows a government to then have a snapshot in terms of both like what has been deployed, where's the gap, who's doing what where, and for them to even see at the touch of a button like which systems are down, right? Because ideally, everything we deploy from now onwards has remote monitoring capacity in it, and hopefully it's also done in a way where it's not exclusive to one particular platform, right? Like, it can connect with different platforms, should be a little bit open source. So for me, the investment on data, where again, whether that sits with a statistics agency or a Ministry of Health or a Ministry of Energy, and different countries will have different answers to that. We like to leave that in the middle. Like, it's not to say it has to be with the Ministry of Health, it has to be with this department. But what we do want to see is having that data set kind of available and even like publicly accessible in a sense, so that every project developer and every donor can come in and say, we want to fund 20 clinics. Within 5 seconds, somebody who manages the database should be able to say, these are the 20 clinics, because they're the furthest from the grid, they have a large catchment population, they have the fewest number of solar panels already on the rooftop, and they're not part of an existing project. Again, very simple way, what we think about, like, simple things that today, in the majority of projects, including one that I'm actively involved in today, it has taken months to get a list of several tens of clinics, and even then, we got the word from our counterpart saying, like, this is the list, but there's still a chance that somebody else is already working on these clinics and we're not aware of it, right? Because like, information doesn't always make it to the right departments within the Ministry of Health or within the Ministry of Energy or between the ministries or at the district level or at the state level. If you think about big countries like Nigeria, there's some information that will only sit at the state level and other information that will sit at the central level. And it's that kind of democratization of information that we really, really want to invest in and want to see governments invest in, because we see the benefit it can have. A second prong, if you will, that on the regulatory side, sometimes a little bit contentious, is around quality. It's around quality standards, both in terms of, we of course want to make sure that all the components that are being deployed into a health facility, but in the country at large, of course, are of a certain minimum standard, right? A minimum quality standard, whether that's ISO, EUV, IEC, whatever standard is applicable to the particular component. We do hope that governments are able to both invest in it, adopt it, and then also monitor it to kind of avoid, subpar components being deployed. That, of course, is a very bad reputational risk for the energy access sector. But I always also like to extend it a little bit further and say, my ideal scenario is that the Ministry of Health at some point can be in a strong position to, say a donor comes in, or a development partner comes in and says, we want to electrify clinics, that the Ministry of Health says, great, thank you, 1 kilowatt peak per clinic minimum. Like, don't come with a solar lantern, don't come with a small solution, because then immediately you're only powering 2 of the 10 things that need to be powered. Power the clinic entirely first, and then move on to the next clinic, right? Like that kind of approach is like, what is the minimum energy requirement of a health facility? And of course, that can be dynamic, right? That can grow over time as more appliances are available, or that can reduce over time as appliances become more efficient. But just that concept of which today, of course, a Ministry of Health tends to not be in that luxurious position to turn away solar lanterns or small solutions. And I'm not saying they should, but I'm hoping that in kind of like in the medium term, again, like we as a sector can take full advantage of the fact that solar PV has gotten relatively so cheap that it is very hard to argue for very small power solutions today. Again, like 10 years ago, yes, like I understand why the best we could do was 200 watt peak, at best 500 watt peak. Power some lights, like maybe a cell phone so they can communicate with the hospital, and the vaccine fridge. That's it. Today, when we think about health facilities, like we think about the staff quarters as well, and security lighting, and water pumping and water filtration. And like, we can think about the whole system and come out with like 2-3 kilowatt peaks as a whole, and that is way more affordable than the 500 watt peak was 10 years ago, right? Like the costs have gone down by like 90% over a decade and a half. And costs will continue to go down, maybe less so on the solar PV side, but definitely on the lithium ion side. We see this massive drop already happening. So systems will continue to get cheaper. So rather than saying, yay, the systems are getting cheaper, I would rather see the system sizes increasing for the same amount of money, so that we prepare these health facilities, not just for today and tomorrow, but also 5 years from now, 10 years from now. Because part of these interventions is, the main part, of course, is making sure that clinics have access to power, that they're able to function today like they were not able to do yesterday. But the other part is also around resilience, right? It's around preparedness. It's around making sure that these health facilities in the health sector at large kind of ready for the next pandemic. And when we, the last thing I'll say is, like, when we measure impact, we like to focus kind of on 3 different types of indicators. One is around quality. So the quality of health, like babies were being born before, babies are being born today, but the quality of the delivery increases. Of course, when you have lighting, when you have sterilized equipment, when you have the incubator ready. Use is another pillar. So quality is one, use is 2, in terms like more people will use the facility at night, during the day. Other people from other communities will come to your clinic because you have kind of 24/7 power and appliances. So use will increase. And then the third one is readiness, where we want to acknowledge that firstly, hopefully globally, birth rates will go down. So it's not to say we need to see more babies being delivered. Like, hopefully birth rates go down. That doesn't mean that your intervention is bad. So it's a relative approach versus the absolute one, but also readiness in terms of, like, is the health facility now able to follow all the protocols? We cannot invent sick people. Like, hopefully no one needs to go to a clinic, but people need to go to a clinic from time to time. It's like, when people need to go to a clinic, is the clinic ready to offer the services that are needed? And that's a similar kind of thinking around pandemic preparedness, right? Like, the next big health shock that's going to happen, not if, but when. Again, like, how do we ensure that there's more resilience in the system, that facilities are better equipped to respond to that? So I feel like I took a bit of a detour, but I ended up with, I think, quite an important point.
No, I absolutely agree that you have. Just to highlight to participants, there's some questions in the chat. We'll be getting to them. So please just give us 1 minute and we'll get to the questions. But yes, lots of important things you've talked about, Luke, the importance of data-driven decision-making. We do have a challenge in Sub-Saharan Africa generally in having data So that's quite a challenge, but we have to start somewhere. We could use what we have. So importance of data in decision making, the democratization of that data so that it can be used for proper decision making. We talked about quality standards, ensuring that we have equipment that have the right standards, not having equipment that comes and then a short while later it's not functioning. It really defeats the purpose. We talked about also looking at minimum energy requirements. Of course, this can vary over time, as you've mentioned, depending on the needs of the health facility and needs to be monitored. I also really like what you talked about, a policy maker's handbook coming out soon. I don't know, you said, is it this year or next year?
This year. Probably by the summer.
Oh, wow, that's fantastic. I think that would really be quite useful for different actors in this space, particularly those in government and just generally all involved in this space. So a couple of questions in the chat. I can see two that are quite similar, that touch on health clinics being close to other infrastructure such as schools, in households, etc. Also, Bernd Levin talks about, it looks like we're discussing health facilities in isolation. So related to just what I've said in the first question, why not tackle a wide customer base with a mini grid that also supplies businesses, households, So what do you have to say about that? Luke, are we looking at this in isolation? Where do we also place these other infrastructure requirements or needs of the community? Mm-hmm.
I'd say in the events where we're looking at this in isolation, it's not because we want to, it's because we have to. So what we have seen, fortunately, is that when mini grids are deployed at the community level, in many cases, schools and clinics are not connected to the mini grid, again, because they're not their individual, they don't have budget autonomy. So it's either the mini grid developer who decides to connect a clinic or a school and assumes that they probably will not pay, especially if they're public health facilities, or they leave them out. And I have seen both situations happening, where like a mini grid developer says this is my social contribution, so I'll connect them. I know they only use 2-3 kilowatt hours a day, so that's kind of my loss, and that's the way it's going to be. And I'll chase some money maybe at some point from the Ministry of Health, but I assume nothing. What we see in many cases as well is the clinic not being electrified, and that is for two reasons. One is because the service provider, the mini grid developer, knows that the clinic is never going to pay, so they're not going to, cannot sign a contract like a household can. So they're not going to connect them from the start. The second reason is sometimes a health facility is not in the center of a community. The health facility tends to be a little bit on the outskirts, also for health reasons, of course. Like, you don't want all the sick population to be in the center of town. You kind of want them, for health reasons, for health waste management reasons. Typically, a clinic is actually a little bit further out, and a little bit, I mean, like 100 meters, right? Like, they're still part of the community, but they're like on the edge. 100 meters in mini grid terms is very costly. 100 meters of distribution poles and wires and all that is very costly. So without the right subsidies, CapEx subsidies, connection subsidies, or other subsidies, typically mini grid developers will not connect them. And that is where, because it turns their financial bottom line worse than it would be otherwise, right? Because they're essentially producing power for free. They know they're not going to get paid, and already, as I mentioned, the mini grid sector currently today is struggling. And that's the reality, right? It is struggling in many countries, whether that is because tariffs are not always cost reflective, whether that is because, as I mentioned, currency devaluation has impacted many mini grid developers in a handful of countries, where, as I mentioned, this is a real example, like a national currency devaluating by 50% over 4 years against the dollar. So, we know that a lot of the mini grid developers are already struggling, trying to find the best possible ways to have a commercially sustainable business model that allows them to attract the right type of funding. So adding clinics and schools or other public infrastructure to it is going to make it even harder. So that's where, is it technically possible? 100%. And it's definitely we've seen it happen where, you know, there's a community-wide winning grid, every load is connected. But I always question the, you know, the affordability question, the willingness to pay, ability to pay question remains. And it just, you know, in some cases, maybe a service provider is able to absorb that. But it's, yeah, it's not because we want to look at this in isolation. It's because we know that in many cases, clinics are kind of being left behind in the business as usual scenario.
That's quite interesting, Luca. I think of my own country. I'm from Kenya, and I think about the initiatives that have been undertaken to electrify schools in particular. Government has been really big on that. I haven't heard too much about healthcare, so really there's some work to be done in that space. Possibly the reasons or the challenges you've mentioned would make it a bit of a tricky area, but certainly food for thought. We have an interesting question also from Michael Alpha, and his question is, can the successes that have been achieved in electrifying healthcare facilities be replicated in other sectors, the industry, in the agricultural space as well? What do you think?
Mm-hmm. I would flip the question and say, can we replicate the success of the energy access sector in household electrification? Or currently, like, everyone, again, like, not my favorite topic in the world, like everyone's talking about productive use of energy. Everyone, because it's, you know, like, the idea about energy, you use it for a commercial purpose, and then somebody earns a revenue, and then, like, it's easier to pay off the solution. Plus, you generate revenue, perhaps you create jobs, and blah, and you offer services. So what I mentioned before on energy as a service is, like, these are models that are existing in other subsectors, agriculture, you know, commercial, SMEs, household electrification, that we're trying to bring into the public sector, bring into schools, bring into health facilities. It's, I think, especially when you think about sectors that have a kind of like a productive, a commercial productive end product like agriculture, I think the case is actually much easier. You know, like, you need to invest in the right way, but if you can invest in, you know, like in agriculture with reliable power and appliances and water pumping, irrigation and cold storage, and some kind of, like, whether it's, you know, like some kind of increasing agricultural yield by processing and milling and whatnot, you can earn that back. Like, whether it takes you 3 years or 30 years, depends on the technology, depends on your yield increase, but there's a business case there. But you don't have that similar, you have it in healthcare as well. It's just impossible to grab it. You know, like, I don't like to talk about return on investments, but we try to increasingly talk about a social return on investment, as in every dollar invested in healthcare electrification can give you 13x, like $13 in social value. Can you touch those $13? No, you cannot. Right? Like, it's social value, it's social return, but you can see that in terms of, like, increased use of the facility. People don't have to travel as far to the nearest clinic that has power, staff retention, patient satisfaction, and of course, like, improved health, right? Like, people live longer and are able to contribute to society longer and are able to earn longer, like that. But again, like, can you capture that? Only if you're able to tax people on their revenue, of course, which we know is very difficult in the majority of countries where you know, where this issue is prevalent, especially in rural areas. But that is, yeah, I think wherever there's a clear commercial return on investment, I actually don't worry about it. We'll figure it out. Where there's only a social return on investment, we need to find the right type of funding and financing to go in that values that social return on investment. But what I can confirm is, like, it is there. Like, we have one study out there that partners of ours carried out, which I'm not pulling these numbers out of thin air. $1 invested in school electrification or in clinic electrification gives you a 13x multiplier. Huge, 13, it's huge. But of course, you know, you as an investor are not going to get any dollars back, of course. So it's not a commercial business case, but there is a social case to be made for investing in reliable power.
Well, yeah, that's quite something. Look, we need to look at the social return on investment. I think this is where you talked about or alluded to earlier about also the need to involve both public and private. We cannot just say this, we leave it to the private sector. We maybe need to reference more delivery models as opposed to business models, because there's this angle of the commercial return, which is quite tricky in this space. I see time is moving very fast. As we said in the title, this is an initial conversation, so clearly a lot of interest. Let me see what's in the chat. Okay, this is a very interesting one by Paola Casati. Given the critical importance of reliable electricity for healthcare facilities and considering the typical budgetary constraints these facilities face, has there been consideration of or successful examples of implementing a community-supported funding model? Briefly, in maybe 1 minute, Luke, or two, if possible.
I'm sure there are examples where communities are able to contribute. I think especially to the longer term operating and maintenance, as in like the capex, the power solution somehow is grant funded, donor funded, or funded another way. It's deployed, but then the question is like, how do you fund the management of the power solution? How do you fund that $3 fuse that breaks, right? Like I think that's where in many communities you've got like a health committee that's set up out of the village elders as well as people from the health facility that come together and they try to fundraise for certain activities or for renovations or for a new appliance. My question back is like, should it be the responsibility of the community to fundraise for power in a public health facility? Right, and I want to put it out there that like a 5 kilowatt peak system, and I'm using large assumptions here, 5 kilowatt peaks at $5 per watt peak, including installation and transportation and deployment and blah blah blah. And people will argue with me here when they can. 5 kilowatt peak at $5 is $25,000. That's the capex. That's the capex cost. Like, I don't know of many small rural communities that are able to fundraise $25,000 for a power solution. So even if that part is donor funded, still you're thinking about like $500 a year, maybe a little bit more, maybe a little bit less for routine preventative maintenance, cleaning the solar panels, remote monitoring of the system, replacing wires, replacing fuses whenever they break, whenever a switch breaks off, because that's regular wear and tear, and that will happen. So it's, that's what I mean. Like when you think about this from the perspective of a community member or a community, it is very expensive. When you think about this from the global community and a climate finance sector that deploys $100 billion every year, it's nothing. It's peanuts, right? It's like it's about trying to find the right audience and trying to find where is our position on this scale.
Absolutely. So, wow, an hour goes by really fast. But just one last, I think there's interest here on the report you've mentioned that talks about the social return on investment. Are you able to provide to us, Luke, perhaps, the particular report?
Yes, I definitely can. I don't know if it's easier to do this via email afterwards, or what I can do is I see it in the chat here. So what I will do is I'll respond it to the chat, and then hopefully everyone can see it. But I just answered it. There's a URL there. It's a report commissioned by OVO Foundation on a project implemented by Energy for Impact in Kenya, which electrified a couple of clinics, a couple of schools, and it's a really interesting document because it's quite it's quite academic. Of course, it's about trying to come up with a methodology of measuring value, but of course a lot of that is based on assumptions like what is the dollar equivalent of staff retention? What is the dollar equivalent of not traveling an extra half hour or hour to the next clinic that may have power? Again, it's based on assumptions, of course, but this is for me the best resource out there that has actually put a dollar figure to this type of investment in terms of the returns that we should expect to see. Like, what is the value?
Okay. Thank you so much, Luke. I think we didn't get to all the questions. This was really engaging. I think somebody was asking about how the unavailability of electricity has influenced health outcomes. What are recommendations to improve access to electricity in healthcare facilities? Well, my recommendation would be, please look for the State of the Market report. It's really, really a really good read. Really. There's an executive summary if you want to begin with that, but there's a whole report, I think about 130 pages. I think you'll find real value in it. Luke, I don't know what to say, the beginning of a conversation. We intend to hopefully invite you maybe again, or we'll have a different format. But this has been a very, very engaging conversation. I'd like to thank you so much, and the audience for taking the time to engage with us in the chat. Please, let's keep engaging. And thank you so much for your time. I will invite Prof. Ignacio to kindly close the webinar for us. Professor, welcome.
Well, I don't have much to say. Thank you, Louise. Great job. I didn't know this dimension of moderator. That's great. And well, thank you, Luke, very much for the large amount of information and the insights that you have provided. We understand that the program is difficult. There are some naive assumptions that we were making that you have really destroyed. And we understand that the progress has to be gradual, and that shortcuts probably don't exist. So I think that we need to continue the relationship with you, and to include your ideas in our training, and to imagine ways in which we could collaborate and extend the ideas, and bring other people also to provide insights. And I think this is all. Thank you very much. And thank you to the audience for the active participation. Of course, we will upload this webinar in our website, so anybody could watch it at any time, and listen into it again to learn. Thank you very much. Goodbye.
Thank you.
Thanks, everyone.
Bye-bye.
Thanks, Louise. Thanks, Professor.